Starting your business isn't just about opening the doors. It's keeping the dream you built secure. With New York Life, you get the financial guidance to make it real. Start today at nyl.com.
Welcome to the Dr. Raj Podcast with Dr. Raj Dasgupta, a show all about educating patients, students, and aspiring doctors about better patient care. Dr. Raj is a quadruple board-certified physician and associate professor at the University of Southern California. He was a co-host of the TNT series Chasing the Cure with Ann Curry, as well as a regular on the TV show The Doctors. And now, here's our show.
Hi, and welcome to the Dr. Raj Show. So, as always, this is not only a podcast for medical geeks out there. This is a podcast for everyone. Yes, it's about learning, but it's also about wellness. It's about being nice. It's always about being yourself. But because this is my podcast, I get to ask my favorite friends and guests and colleagues and doctors to come on the show and to make all of us smarter. And today we do have a special guest. I don't know if many of you guys know this, but I had the opportunity to be on a TV show called Chasing the Cure. And I actually convinced one of my colleagues from Chasing the Cure to come on the show. And this is going to be Dr. Sheila Sahni. But as always, I got to give the background. So bear with me. I know, Sheila, you're listening. You could just listen to me while I flatter you right here. So Dr. Sahni is an interventional cardiologist and director of the Women's Heart Program at Sahni Heart Center, part of Hackensack Meridian Health Medical Group in Clark, New Jersey. She is affiliated with Hackensack Meridian Health in New Jersey and Mount Sinai Hospital in New York. She graduated summa cum laude, bragging all the time, from Georgetown University School of Nursing and Health Studies, and received her medical degree from Georgetown University School of Medicine. She completed her internal medicine residency at Mount Sinai Medical Center in New York and her fellowship in cardiovascular diseases and interventional cardiology at David Geffen School of Medicine. Oh, it's UCLA. Everyone, Dr. Raj is USC all the way, but Dr. Sahni is nice. It's okay. Where she served as a chief fellow. She's an active member of American College of Cardiology Women in Cardiology Committee and the Society of Coronary Angiography and Interventions Women in Innovations Committee. Her clinical interests include prevention, lipid management, women's heart disease, high-risk complete revascularization, and radial interventions. She has been a pioneer in the use of social media for cardiovascular disease education, patient awareness, and advocacy. Dr. Sahni regularly appears in the media. She most recently appeared as a physician expert on TBS and TNT's groundbreaking medical series, what I just mentioned, Chasing the Cure. And that was a show, and I'm already tearing up because that was such a great show, as a platform to crowdsource a diagnosis for patients with unsolved medical mysteries. And with that said, Sheila, thank you for being with us today.
Raj, thank you for having me. It's an absolute honor to be on your podcast. I'm so proud of you for everything you're doing to inspire and enthuse the medical community. We're all really lucky to have you. Thank you.
Wow. No one can see this, but I'm blushing a little bit. I know I'm brown, but my skin's getting a little red here. So Sheila, this is all about you today. So the first 5-6 questions are to get to know each other, meaning that my audience wants to know who you are, So when I forgot the most important reason why you're here today, Sheila, February is, Sheila, you tell me, what is February?
It's Heart Month. It's a whole month dedicated to heart disease awareness. And for so long, heart disease was thought of as a man's disease, but it's not. It's also a woman's disease. So we really look to February as a time for self-love, not just about Valentine's Day hearts, but about your own heart, and recognizing that it's your number one threat, man or woman.
Well said. Well said. And we're going to get, don't worry, I got all the medical questions for you about that coming up. But let's start off with like some simple ones to kind of get our feet wet a little bit. So, hey, Sheila, where were you born? Where did you do your undergrad? And what was your major in undergrad?
I was born in Plainfield, New Jersey, and spent most of my life growing up in Rumson, New Jersey, which is right at the start of the Jersey Shore, not the one that you see on television, but very much love New Jersey. And that's really where I came back to practice. But I did a majority of my training on the East Coast. So I went to undergrad at Georgetown. I was at the School of Nursing and Health Studies, where I had a very nice time focusing on sciences that were focused on human science. So that was my major. I was also an art history minor.
Okay. So, we finally get to college and Georgetown is awesome. I mean, way to go, And you know what I love about you is you're not snooty like some of those Georgetown people. They get really snooty sometimes, But I mean, was your major a traditional, I want to be a doctor major, this health sciences thing? Or did you not know what you wanted to be when you were in undergrad?
So I knew what I wanted out of my undergraduate career. So we should really back up, because I think that I started to really focus on my professional goals right at the transition of 8th grade and 9th grade. And so when I took AP biology as a freshman in high school, and I dissected that fetal pig, that's when I knew I wanted to be a doctor. Like, that's what I knew. And I remember, I'll never forget, I was learning about salivary amylase and digestion. And I got so excited about how amylase breaks down carbohydrates and starches in your mouth. And I was talking about it at lunch. And, I always really liked physiology. And then as I was choosing my schools, I loved that Georgetown had a School of Nursing and Health Studies. So I focused on the health studies aspect because I knew I wanted to be a doctor, and I loved that you could be a health studies major and major in human science. So I didn't have to take biology. I could take human biology and pathophysiology and pharmacology.
Okay.
What I learned later is I was basically signing up for mini med school, which was, stressful. But at the same time, I probably would have been stressed either way. I was very focused on my career. But the benefit of being a health studies human science major was that I learned and I got exposed to the cardiac cycle very early. And that was when the world opened, the lights flashed. I saw the Wigger's diagram, and that was it. I remember I drew it in different colors, highlighters, and the idea that the heart as a pump can do so much. It houses its own electrical activity. And I was only a sophomore in college, but I knew right then and there that I loved it, that I really wanted to be a cardiologist, and I wanted to see this through. I was lucky enough, I got into Georgetown's early assurance program. So sophomore year, the summer between sophomore and junior year, I applied. And I was selected, and I was exempt from the MCAT. So I was accepted to Georgetown early for medical school.
Wow.
And I got to focus my second half of undergraduate on my art history minor and studying the role of art therapy in cancer patients.
Man, so number one, that means you must have been a top-notch smarty, because that combination undergrad med school thing, very few universities offer it. I know USC offers it, but it's hard to get into, And that kind of makes sense because, I was interviewing one of my other buddies and they did a similar combination. You must really know what you want because, let me play the cultural card here. One thing that me and you have in common that we're two of the brownest people around town, and I got to, if you were to put me on the spot and say, Raj, why were you a doctor? I don't know. Maybe it's because my Indian relatives were going to kind of beat me up if I didn't become a doctor. Or maybe all the other Indian relatives are gossiping that Raj is not going to be a doctor because he's always goofing off. Was there some cultural stress? Because I know you're surrounded by doctors. Your family's like beyond smart. And was there some, be honest, I'm your bud. I'm your guy. Was there some stress culturally to be a doctor?
The storyline of me wanting to become a doctor is very genuine. Okay. But the only thing I could say, there was no cultural stress. I think that my little sister became a dentist and my older sister became a psychologist. So we naturally like, health studies and helping other humans. I think that's a part of, maybe the Sahni girl gene. But my grandfather, who was a military physician in India, came here and in the late 70s and used to always ask me, Sheila, when are you going to become a doctor? And the beautiful part of this story is that his voice is always with me. He missed my medical school application acceptance by 6 months. He passed away with pancreatic cancer, but I know, very sad. But he is somebody who I really believe wanted to see that through for me.
Yeah.
But other than that, there was no other cultural pressure. And I would really encourage, South Asians who feel that pressure. There are millions of careers out there. We shouldn't feel that pressure because, Raj, the truth is you wouldn't be doing what you're doing unless you loved it. And same with me, right? So I think that's the key. You've got to love what you do. So then you won't work a day.
So after this interview, I'm going to thank my dad for locking me in the closet and making me study. I'm just joking.
Yes.
Dad didn't do that. But speaking of dads, is your dad and mom like the luckiest parents? What exactly did they do to get a dentist, psychologist, and a cardiologist? What did they do? Is there special potions and prayers? Do they put sugar cubes in front of the elephant a lot or something? How did they do that?
Oh my goodness. I would say that my dad definitely took a lot of pressure off of us. In medical school, he always told me, Sheila, P equals MD. Can you please take it easy? And even my little sister, going to dental school wasn't enough. Graduating from the third dental school in America wasn't enough at Tufts. She had to go to UPenn and become a periodontist. So I think that it's something about us seeing our immigrant parents, how hard they worked. Yeah. That work ethic was ingrained in us. And my mom really valued education for us. She never spoke to me about, who are you dating? When are you going to get married? When are you going to start to have children? She really focused on valuing our education and our careers. And I think that slowly that led to us creating our own set of goals and our own aspirations and dreams. My little sister likes to equate her field as really the cardiology of dentistry. It's male dominated. It's difficult. I look at the stuff she does and I'm like, oh my goodness, you're an oral surgeon. This is crazy. But I think that a lot of it was self-inflicted. But I think there's that natural feeling you want to make your parents proud.
Yeah. Oh, 100%. For me, I like what you said. My dad's from Calcutta, India. He was poor. They did everything for me. I'm sure your folks did everything for you. I would have really messed up if I didn't do something good in general, But let me ask you a med school question. So give me the classic best memory, best moments in med school, and then tell me what's one of the toughest, worst things about med school. So I have a lot of med students that listen to this. So give me a good thing and give me a bad thing.
Okay, I'm gonna start with actually the bad thing.
Okay.
And I think it was more. So I went to a very difficult med school. Georgetown was very difficult. They did not have a pass-fail system, and I think that the pass-fail system would have been very psychologically beneficial. I remember memorizing minutia just to try to get an honors. And deep down inside, I should have been focusing on studying from those high yield books and just focusing on my step scores. I think that I see benefits in going straight through, but I also see benefits in having some level of break or life experience. I think I was suffering with a lot of stress in medical school, a lot of anxiety, and a lot of imposter syndrome. Medical school was extremely humbling. I graduated top of my class. Damn. And my experience in medical school wasn't, that transition wasn't exactly the same. The way you have to study, the amount of information that's being thrown at you. And I really encourage, I hope administrators are listening to this, because the way that we teach needs to change. We need to approach medicine a lot more holistically and start to build a lot of those skill sets much early on to allow our physicians who are suffering from burnout to be more balanced, because it's a marathon. It's not a sprint. Yeah. And I think that that's something that if I could talk back to myself and see that girl who was grabbing that fourth cup of coffee and sad because she can't get through all the pre-notes for tomorrow's lecture, I would tell her to hold herself and to tell herself it's going to be okay because it's a very long road, and I think that that's the wisdom I have now. And it's easier said when you have a road of accomplishments. It's harder when you're trying to get to the finish line and you still feel that I need to graduate. But my dad was right. P equals MD. And I should have just kept that in mind. So I think listen to yourself and it's okay to say, I really need to take a break, or I need to rethink the way that I'm thinking about myself. I remember my friends telling me, well, Sheila, take it easy. It's Saturday. And I say that to myself now. Maybe it's 12 years later. But one of the best memories I have of medical school, besides some of my incredible, really dear friends who were just at my wedding about a year and a half ago, is that Georgetown valued treating the whole person. So we have a motto, a Jesuit motto, cura personalis, treating the whole person. And I already had a taste of that when I was working with cancer patients, but I absolutely loved that we were put into the hospital setting as first years. I learned how to interview patients just for compassionate listening. And it was really when I started doing my away rotations as a fourth year, I recognized that I was different. A Georgetown medical student was different than other medical students. I had a capacity to understand, listen, and be empathetic that a lot of other physicians, when I was rotating at hospitals in New York, they hadn't seen. And also, we had a very rigorous third-year medical school clerkship training. So as a sub-I in my fourth year, I was seeing as many patients as my intern.
Wow.
So I was a very strong medical intern beginning at Mount Sinai. And I'm very grateful for that. That was a very good memory.
No, and just to comment in general for the listeners, I think that you nailed it, Sheila. I mean, a couple of things are changing now is, USMLE Step 1 is now pass fail. They're not doing the USMLE Step 2 clinical skills. They're encouraging more, patient care hands-on in the earlier parts of med training. It's just, it's a shame that it's not going to affect us right now, but the things that you're commenting on, I think they're slowly making that change. You know what I mean? So, after med school, you need to make the decision what to go into. And, for listeners, you could be a surgeon, like OB-GYN, you could do the road, radiology, optho, anesthesia, stay on the road, why internal medicine? You probably could have gotten into any of those I just mentioned. Why internal medicine?
Well, I knew that I wanted to be a cardiologist since college. And I think that, I used my third year very strategically. So because I knew I was already focused on medicine, I did it a little bit later after I had my hands wet with OB, peds, surgery, and I got that out of the way. And I knew it when I got to medicine that this was what I wanted. But to solidify that, I did focus on cardiology electives in my fourth year. And really, when I walked into the echo lab and I saw the two-dimensional image of the heart, in parasternal long axis view moving, and that was it. I was done. I must have done 4 electives in cardiology. No, wait, 3. I did 1 at Georgetown, 1 at Mount Sinai, and 1 at NYU. And then just to make sure I wasn't biased, I did an elective in rheumatology. And I did love rheumatology.
Yeah, my wife's so proud of you.
I know. But, I never really enjoyed injecting joints. So that's when I realized, cardiology is where it is.
Yeah. Well, you kind of led into my next 2 questions, but let me just kind of turn it around a little bit. So, for those who don't know, Sheila's dad is an awesome cardiologist. I'm just going to assume he's pretty awesome. I saw the pictures. He has his own, he started his own heart center. That's pretty impressive. How much of cardiology was that smile on your face and seeing the heart and echo versus, hey, let's be honest, Sheila, it's pretty sweet where your dad could hand you the baton and say, take over this heart center called the Sahni Heart Center. So was it a balance of both that made you a cardiologist, or is it, Can you kind of answer that one?
Yeah, I have an amazing memory. I was a senior in high school and I wanted to see my dad cast, right?
Okay. Cool.
And he stuck the groin, so when we cast, for everybody who's listening, it's a coronary angiogram, and it's a percutaneous procedure. So we have to get access to the largest blood vessels in the body. And this patient, we couldn't do radial, or I don't even know if radial was being done in New Jersey at that time, because this was 2001. So radial intervention started my father began them in New Jersey in 2003. So 2001, here I am in the fall, senior. I drove myself to the hospital. He stuck the groin and I almost passed out. When I saw the blood rushing, I don't know what happened. I remember him pouring me a glass of water when the case was done. I was getting really hot. And after that, I pursued. That was high school. So then, college, and he knew I was interested in cardiology, but he had very little to do with asking me to do anything, or, he wanted me. I think he mentioned derm, endocrine. He used all of those. I don't think that he was making gender stereotypes when he thought that I would be better off in those roles. I think he knew that cardiology brought with it a bag of responsibilities and, thunderstorms that he might not want his daughter to experience. Right. And what was interesting is that when I was younger, I used to go to the nursing homes with my mother, and she would dress me up. We had 3 girls in the house, so she had to pull one away, and it was usually me. And I loved seeing older patients. I liked chronic care. Sure. So medicine really jigged with me. I liked the longevity of seeing the patient from start to finish, through the hospital admission and then back in your office. The journey of my father. So as I would go to conferences as a med student, he was listening. We were looking at, I remember when the syntax trial came out, we were talking about it, stenting and surgery head to head, New England Journal of Medicine. And this was throughout he knew when I was at Mount Sinai, one of the top coronary labs in the nation, probably the world. He knew I loved it. But at that time, he was really excited about cardiac imaging. Sure. And I got excited about cardiac imaging. And I went to UCLA wanting to be a cardiac imager. I must have scrubbed 64 transesophageal echoes thinking I was going to be like an imager for TAVR and mitral clip. And let me tell you, Raj, when I would go, speaking about like stress and nervousness, about when you put so much pressure on yourself, when I would go to intubate the patient with the probe, every now and I was like 1 for 2. I would be like, I would get, I would really want it to go well. And sometimes the patient, it's a difficult procedure. You have to get the patient to relax and sedate them enough, lidocaine them enough in the back. But when I walked into the cath lab, I was getting the sheath in before the attending walked in. I was so comfortable. I was so happy. I was so confident, and I didn't care about it. I was like, oh yeah, it's cath, and this is awesome. At the end of my first year, one of my attendings was like, are you sure you don't want to do this? Because you've got great hands. Nice. And that's when I took a step back and I was like, wait a second. And I was doing a rotation in CT MRI. Okay. That's when I realized advanced imaging is a lot of work with advanced software. Sure. And I'm not a computer person. Yep. So I need to really be thinking about what I'm doing in my career. And all of a sudden, Providence fell suit. I switched out of imaging. I moved into the cath lab as a second-year fellow. And then I jumped on my way to a really rigorous cath conference national meeting. And that's after seeing those live cases, I knew I could do it. I knew it was what I wanted to do.
Man. No, and it kind of answered my second question, was why interventional? And you know what? And I love the fact that you actually explored non-invasive things. I think sometimes people forget the CHF specialist, the medical cardiologist. They're just as important, because intervention is pretty cool, though. And I'm sure nothing beats the feeling of opening up a clogged artery, draining a pericardiocentesis. And there's so many things you guys do. So I am very impressed. So let me kind of switch gears a little bit. And
I just wanted to add one thing. I know that was like a long-winded response, but about my father. So I made my father come to the TCT meeting with me. This was October 2014. Okay. And in terms of, he was once I told him that I wanted to do it, he was all about it. But I remember looking at the live cases and I looked at him and I said, Dad, Daddy, do you think I could do it? And, you ask your father, do you think I'm going to actually be able to do this? And he looked at me and he said, yes, beta. And beta means child in Hindi. And that was when I was like, okay, all right. I needed to know that my dad can think I'm going to do this, and then, so I think that in the end, it's a really beautiful story and it's incredible, but the passing of the baton definitely didn't happen like I was, from the beginning. It was like a longer journey. And I really think it was beautiful.
For people who are listening, there is a picture, and I feel like I'm a stalker now, that you just put on your Instagram where it's like you and your dad. You know what I'm saying? You just received, and it was such a beautiful pic. And you can tell that smile he has in his face that he's like, this is my daughter. She's the bomb. But, okay, let me switch a little gears because I got to save some time for all these medical questions. So let's talk about something that we share together. Let's talk about chasing the cure. So, I don't even know the answer to this. So how did you get plugged into that show? What was the story behind you getting there? Because remember when we first showed up, there were like all these people there in the room. So for those, it was like, I remember one of the first times I met you, they invited me over and there was like 6, 7, 8 people, but there's only like kind of 4 spots in the show and everyone's kind of feeling each other out. And you were very, very nice and sweet to me. So what was your story? How did you get there?
I think I was an 11th hour find. I was contacted pretty late. I was contacted in the spring. So I got my first email end of March and I started doing video interviews sometime around April. And I met Ann. The next thing I know, I'm meeting Ann Curry Memorial Day weekend. So end of May. And then they want another meeting for producers in the Time Warner. And I remember because this all coincided with my upcoming wedding. And I had a tasting at the Pierre. So I worked it out on a Friday, but I was really, after talking to one of our colleagues, Vaughn, who told me he was interviewing since August, I recognized that I was found by Ann.
Nice.
And Ann she found me. Ann found me. And Ann was looking for a real doctor who was in the community. And she found me through my social media work. I had built a digital presence.
Okay.
Yeah. So she had searched for a cardiologist. And, this story is kind of secondhand. So we can always vet it through her. But she found me. She was looking for something unique. And she really wanted a doctor that was working in the community.
That's great.
Yeah, she was very, very moved by the practice that I had joined with my father and the kind of patients that I was treating and a lot of the work that I had done in the digital space to help grow the understanding of interventional cardiology and get cardiologists on Twitter. It really worked with what they were trying to do with chasing the cure.
So let me ask you this. I remember when I first met you, you did some media stuff, but not an overabundance of it. So this is kind of like the first time like you were on the couch. We used to sit on the couch and practice. And in the beginning, because I was very fortunate to have some media practice before, I was like, whatever, I'm on the couch. But I like to stare at everyone else to see what they're doing. What was the hardest part of being a community cardiologist, doing your doctor thing, which you do great, and suddenly trying to be on a TV? What was the hardest transition there for you?
Just knowing that my credibility is all I have.
Yep.
And that once you are put on national television, you've got to be extremely careful about what you're going to say and what you're going to support. And I think that we were really incredibly lucky to have Ann backing us up. She listened to us. She was our voice. She supported anything that we said that we didn't feel comfortable with. And I don't know if in media we'll ever get that same experience again, but I do know that having met her and having worked on that show, I know what I can advocate for. And I'm a much stronger media presence now, having done Chasing the Cure. But the other thing was just getting really used to a lot of those lights. And it was a live show. I mean, when I tell people that we did this live, they can't believe it. I mean, it's so different now. The experience I have working with people, moderating it was a high. It was incredible to work with the best of the best doctors like you, like James, like Vaughn. I loved it. It reignited so much passion and love that I have for both media and medicine.
I would say if you were to switch the question around, one of my favorite things to do on that show was, remember we did this thing where we discussed the patients in like a boardroom. There was like a whiteboard. Like we would just goof off so much behind the scenes. Like I remember Vaughn was always like, I don't know, like remember
he was always drawing
like a certain food, and we always used to tease him about it. It was like,
oh my gosh, he was so funny. And you had all the clinical niblets. You were like the mini med school professor with the clinical niblets.
Well, I mean, that whole thing was super fun. And, I kind of warned you I'm going to ask you this one. So, hey, forgiveness if you don't remember any names or anything like that. But what was your favorite case? You know what I mean? I already know mine. Mine was when I got really a big chance to deal with a big pulmonary case. So, the last one I did when they filmed it at USC, that just was very special to me. Was there one that was really special? They're all amazing. Anyone listening, you're all amazing. But which one was your kind of favorite one?
I'm really grateful that we were able to air the case of Kelly, who had chest discomfort, but it was extremely vague. And she really did not have a thorough synchronized cardiac workup. Mm-hmm. And we were able to give her that. Yeah. And I feel that, both not only helping her, but also just getting that knowledge out that women don't present like men, that, cardiac disease needs to be ruled out efficiently. You can't just start doing it in silos. We need to do the workup and we need to complete it so we can rule out heart disease, which is a woman's number one threat. And she was not aware of that. She also wasn't, I'll never forget, she was talking about her legs. And so I take care of a lot of women who have leg swelling. And a lot of physicians don't think about doing venous mapping, diagnosing venous stasis and reflux. And I also brought that to her attention. So being able to, share the case with a cardiologist from Cedars-Sinai, discuss it with some faculty at UCLA regarding the perfect imaging test for her, and really getting to dive in deep of what microvascular disease is, which is when women have disease in the smaller blood vessels of their heart, and it creates what can be a very vague chest pain syndrome. Yeah. That was really something I enjoyed.
Sheila, do you remember that? For some reason, I always remember that when our patients on the show that we discussed, some of their issues, they're always stuck on steroids for some reason. Was that like a big thing? Like, I think my recommendation is get off the steroids for some reason. That was like
everybody wasn't. It's so true. Yeah. It's so true.
And I can't tell them how to get off of them, but I think that will solve all their problems, Yeah.
All
right. So I'm going to switch gears again. So now you're going to be Sheila, the cardiologist. Is that cool? All right.
Yes.
Okay. So, like you said, this is a very special month for heart awareness. I want to focus on heart disease in women. I'm going to ask questions about understanding the symptoms and risk factors. So, number one for Dr. Sahni. So what are the symptoms for a heart attack in women?
The symptoms for a heart attack in women are very different from the symptoms of a heart attack in men. So men tend to get that very typical Hollywood heart attack with crushing chest pain, but women don't always get chest pain. In fact, the majority of the time, women are presenting with shortness of breath, but sometimes it can be even more subtle. It could be a new onset migraine headache, some upper back discomfort. It could be nausea, heartburn, and just overall not feeling well. And that's why it's really important for women to recognize that anything that comes on in their body that's new, that's either between the navel or the nose, that comes on with either physical or emotional exertion, needs to get checked out immediately.
Nice answer. Oh my God. So this kind of leads into our second medical question, which is going to be, risk factors, right? I think we all want to know about risk factors. And, are there some specific risk factors for women? And because I think if you just put me on the spot and say, what are your risk factors in general, Raj, for men and women, you got to say, diabetes, hypertension, cholesterol. But is there something, those are all important. You could elaborate on that. Are there some special ones for women that you want to mention besides those?
Yes. And just to complete that list, tobacco use.
Now, dude?
Yes. Well, it's so important to remember tobacco use, sedentary lifestyle, obesity, family history, and age.
Okay.
But women are also at risk for heart disease. In fact, it begins as early as pregnancy. Pregnancy is a woman's first stress test. If you've suffered high blood pressure, whether it was just high blood pressure or preeclampsia or eclampsia in your pregnancy, you've quadrupled the risk of early onset heart disease. And same with gestational diabetes. Even if your blood pressure and your diabetes normalize after delivery, you have suffered vascular changes that need to get checked out and actually put you at risk. So that's first and foremost. All my pregnant women who are listening, if you know anybody that's been having gestational diabetes or high blood pressure in pregnancy, get them to a heart doctor early so we can get their risks assessed. But the other thing is women also with autoimmune disorders. So stuff that your wife takes care of the time.
You remembered.
Yes, rheumatoid arthritis, lupus, these conditions naturally being so inflammatory also inflame the endothelial lining and the blood vessels and predispose to heart disease early and make other compounding risk factors more atherogenic. Similarly, women who have had breast cancer, haven't gotten chemotherapy, radiation to the chest, they're also at risk for heart disease, as are women who go through menopause and women who have depression, anxiety, generalized anxiety, psychosocial stress. This is a very big risk factor for women presenting with heart attacks.
I wouldn't have guessed that whatsoever. Now I'm going to put you on the spot again. You got to be careful. So some of my listeners may not know, what does it mean to have preeclampsia, eclampsia? These are very specific OB-GYN terms. I'll help you out, but I'll let you go first. Can you explain to my audience what is preeclampsia, eclampsia?
So preeclampsia is basically it's a vascular condition where your placenta starts to clamp down and raise your blood pressure. And it's a specific blood pressure cutoff. But what matters the most about preeclampsia is the presence of proteinuria in the urine. So the way that it would, you would start to feel uncomfortable when you go in, your blood pressure is going to be elevated. Typically, systolic is greater than 160. We see the diastolic range greater than 100. But then we do the urine dipstick and we see the presence of proteins in the urine. And even if you don't meet that cutoff, the presence of protein in the urine is a risk factor for heart disease.
So our OB-GYN doctors, are they doing a good job in letting the patients know, like, hey, you got this, please follow up down the lines? Or are those risk factors in decades from now, or are things that need to be addressed soon after the pregnancy?
So, ACOG is really trying to work with the ACC, because what happens to a lot of women is that they lose their insurance after they deliver the baby. Mm-hmm. And that's one of the biggest issues. Okay. We also see postpartum preeclampsia happen as well. Okay. So I've had a mix of both. Some women who have gotten lost and other women who are still able to keep up. But we're working on this on a policy level to help, access to care be extended so women can get appropriate treatment after their delivery. But sometimes it's just forgotten. So it really depends on if you're practicing at USC, which probably has MFM, high risk pregnancy, you're probably going to be okay. But I'm noticing that in the community, a lot of my 50-year-old women, I ask about their pregnancy. Yeah. And I document and then I treat them more aggressively because I know that their endothelium is not normal.
Now you gave me really dorky because I'm loving this. So also for my audience, eclampsia is just having seizures. Everything Dr. Sahni said, plus unfortunately you have some seizures. But I'm just asking it randomly. Med students know about peripartum cardiomyopathy. Is that something that's real? Have you seen it before? And this is kind of a heart failure because of the pregnancy. Is it kind of like something that just resolves its own, or if you have it, is that your new heart the rest of your life? Can you comment a little bit about that?
Peripartum cardiomyopathy is very scary. Okay. It's very, very scary.
Have you seen it?
Yes, I have. I've seen women have to get transplanted because of it.
Oh, Jesus. Oh, my God.
So every case is different, when it starts to present. But once you are developing heart failure in pregnancy, you need to go to an advanced heart failure specialist.
Okay.
So because you need to have access to support devices based on what's going to happen. And you need a very high risk team. So you need access to cardiac anesthesia, high risk OB. And depending on what happens, obviously the safety of the mother and the safety of the baby is first and foremost. And management and discussion of this would really, ACE inhibitors, which are our classic medications, can't be used in pregnancy, right? So you've got to get the baby out safely, and then you've got to deal with the mother's cardiomyopathy. And depending on how severe it is, obviously if she's in shock or some she's developing cardiogenic shock or failure, you're going to have to start thinking about a support device such as LVAD or maybe even transplant. But if the woman is okay and the heart is just weak, let's say the ejection fraction is 40%, you're going to put her on guideline-directed medical therapy, and you're going to wait and see if the heart can recover. But the discussion of the second pregnancy is very high risk. Once you've had peripartum cardiomyopathy with your first pregnancy, you have a predisposed higher risk of having it in the next pregnancy. And we usually don't encourage repeat pregnancy.
Let me ask, this is kind of an odd question, but another thing that worries me or patients are people who have high blood pressure in the pulmonary vessels. I think we call that pulmonary hypertension. So my question to you is, here at USC, we kind of fight with the cardiologists of who should be the master of pulmonary hypertension, pulmonary arterial hypertension to be precise. Do you take care of pulmonary hypertension patients? And who do you think is the real master? Is it us, the pulmonologist? Are we the best? Or is it the cardiologist?
I think the best team is the one that works in harmony with each other. So I think I've seen some institutions do it really well. And I'm lucky to have trained at both of them. In Mount Sinai, UCLA, probably USC. It's really nice when you have a cardiologist that specializes in right heart cath.
Yep.
Not every cardiologist does a right heart cath the same way. And to all my interventionalists out there, to all my cardiologists out there, and my heart failure specialists who are listening, you all know what I'm talking about. It's just there's nuances and subtleties, and we need to respect niches. I'm an interventional cardiologist. I love radial intervention. I love complex coronaries. I love women and heart disease. Is pulmonary hypertension my bread and butter, especially being in the community? No. Okay. And I have no shame in doing a great right heart cath, but where I'm existing in my practice, I would send to a pulmonologist.
Nice.
Yes, absolutely. Especially, when I start thinking about the WHO classification and the management and the different use of the vasodilators, we do the pulmonary reactivity testing, yes, in the cath lab. Okay. But at the same time, I think the concerted management, when you start taking care of patients with ILD, you need your pulmonologist on board, managing that patient, oxygen levels. So for me, I think it works best when you have a really great, either a heart failure physician who's doing your right heart cath, who is looking at the RV, has access to cardiac MRI to really look at the right ventricle, the pulmonary pressures. I did a lot of research on that when I was at Sinai, and then works with the pulmonologist. I think that is one of the most beautiful relationships in managing pulmonary hypertension.
No, good answer. Very PC. Politically correct on that answer. All right. So back to the heart again. Here we go for women. So this is actually one of my, you have a bunch of fans. A lot of my med students just adore you on the show.
Oh.
Yeah. So, they want me to ask you, is heart disease something only older women should worry about? What do you think?
No, it's never too young. I had an Instagram post on this recently. It is never too young to begin starting to be. Also, Raj, we're seeing an epidemic of heart attacks in younger women in their mid 40s. And it's all, the epidemiologic data is all pointing to uncontrolled risk factors of obesity, diabetes. And therefore, the decisions that we're making in our 20s and 30s, they're affecting us.
Yeah.
And that's why it's never too soon to begin a heart healthy lifestyle.
Nice answer. Now, I'm going to take a small detour from women. Just ask you, I'm going to do one of my own questions, with all the COVID stuff going on, people always still ask me, what is the number one killer of both men and women in the United States? And I always say it's heart disease. So, there's a big question that occurred this past year, which is, where did all the heart attacks go? Sheila, are people not having heart attacks anymore during the pandemic? Where do they go?
It's a very, very, it was an eerie question. The emergency rooms were empty.
Yeah.
And so many patients were scared. The amount of phone calls that we got of patients having chest pain that didn't want to go, that didn't want to be seen. I was blessed to do I did a lot of STEMI call during COVID. I had 3 real STEMIs.
Wow.
And I'm so proud of those patients. But I'll never forget one of my patients who I just recently saw, he's doing great. I remember when we finished his stent, he said, I want to leave. I don't want to be on the floor with the COVID patient.
No,
and I was like, you're not going to be.
I know.
You're not going to be. Please, you need to stay.
Yeah.
You had a massive heart attack. And I think that's a real fear. We made a lot of pushes, both Sky and ACC, with national campaigns to encourage patients to get seen in a timely fashion for their symptoms. It is still the number one threat. And we really need our patients presenting to the hospitals. It was a very scary thing, what we saw.
And, earlier in the pandemic, much, much earlier, there was an article out there, and I think it may have been some kind of cardiology guideline. Maybe you could help me without this, that they were recommending doing lytics, blood, thinner breaker downers instead of stenting because of less exposure to patients and stuff. Did you see that in your business and in New Jersey, that maybe you're like, you know what, I would stent you, but right now I'm just going to push the lytic instead? Can you comment on that?
Yeah, there was that paper, and it was, it was very impressive to see all of those leaders between ACC and Sky really come together to get that paper out, really for community labs that didn't know what to do. So we were lucky in the Hackensack system at JFK Medical Center, where I do a majority of my cases, to really change the filtration system. Okay. We were able to get anesthesia on board. So we were able to intubate the majority of patients in the emergency room, bring them safely so that we were able to limit exposure. But there were, so the challenge then is, STEMIs got brought to the lab. We did not use lytics. So we took care of STEMIs. We treated them as we did. But you did see a lot of troponin elevation that did not need to be brought to the lab. Okay. And that's because COVID-19 creates a myocarditis. It creates so that was something that had to get managed. And I think we were lucky that, scary and lucky at the same time, anticoagulation is being used in our COVID patients, right? Because we see it's a thrombotic cascade. We were learning that all on the fly back in March, but now we know that much more clearly a year later. So I think people did need that paper because they were at a loss. Yeah. They didn't have the resources. We didn't have the PPE. We needed help. And I think it really speaks to the cardiology community about how fast they can get the data out. And really, they were a force to really show that, we're going to do conferences virtually and we're going to get this paper out. And we needed answers. And they really tried to help as many physicians as they could.
All right, because you answered that really good, you get another COVID question. So, anyways, no, I told you I'm just going to kind of wing it because I love your answers. I think we all were humbled, during this pandemic, because every time I open my mouth, like 2 days later, I misspoke because things are always changing, right? So, do you remember when there was a no-go on ACE inhibitors? They're like, ACE inhibitors, and for my med students, they're ACE inhibitors. That's one of your go-to drugs in certain, coronary artery disease cases, heart failure cases. Did you have patients call you up and say, "Hey, let's stop this medication"? Did that affect your management in any way?
Yeah, there was before all those, there were a number of papers that finally came out that consolidated the data and said that it makes no difference. But there was a week where I was really getting nervous. And there was a week where I convinced myself, okay, I can keep my patient on it, but I can't start it new.
Yep.
There were a lot of patients that called. When I think back to that early time, there was just unsolvable, unquenchable fear of making the wrong decision, of what was being said was that if you're on an ACE inhibitor or an ARB, you have an increased likelihood of being more receptive to the infection, and that the infection would be more infectious and dangerous for you. It was very scary. It was a very difficult question. But after reading enough data, I was able to safely keep my patients on the medication. And like you said, I lean on ACE inhibitors and I lean on ARBs all the time for blood pressure control, for heart failure. So it was a scary time, but I'm glad that, again, to the science community, that we were able to clear up that there's absolutely no impact and we don't have to be worried.
No, totally. All right. Back to women. All right. So I think this is an appropriate question now as we talk about risk factors. Does it only affect older women? So what can women do to reduce their risk of heart disease?
So I have a really amazing fact. Okay. I want women and the young girls who are listening, tell your mothers, tell your sisters, tell your grandma. Risk factors really matter. So you've got to hashtag know your numbers, your blood pressure, your cholesterol, your diabetes risk, and you've got to get the numbers from your doctor because the guidelines change. Don't let any doctor tell you, oh yeah, your blood pressure is fine. Oh yes, your cholesterol is fine. No, get the exact number, get the top number, get the bottom number, and get your cholesterol numbers because our guidelines changed. And it's really important to know those specific numbers because if a woman does not develop a risk factor for heart disease before the age of 50, her lifetime risk of heart disease has now reduced to 8%.
Oh,
that's amazing.
That's amazing. I should put that as the title of our podcast, dude. That's
right?
Awesome, dude.
But if you have 2 or more risk factors at the age of 50, you now have a 50% lifetime risk. So if I told you, right, that like if what you're doing in your 30s and 40s could impact the presence of high cholesterol, diabetes, and high blood pressure, and you could completely reduce your risk from 50% to 8%, who wouldn't want to sign up for a heart-healthy lifestyle? Who wouldn't want to sign up? So, I want everybody who's listening to recognize it is so easy. I love telling my patients, you've got to eat clean, eat green, keep it lean.
Oh, dude, you're like phrases today. Oh my God.
But it's so true because we get so confused by diets. I mean, one of the best diets is the Mediterranean diet. It's been clinically proven to reduce the risk of heart disease. But breaking that down in a visual, you want to be eating good fats from nuts and avocado and olive oil and portion control. Eat lean fish and lean meats and stick to whole grains. And it's important for women to know as they get older, right? After menopause, their cholesterol profile will change and weight gain goes up. So women have to start to be attentive to portion control to keep their calories down and to make sure that they're getting enough exercise so that the weight stays the same.
So this is great. So you set me up for my next question, which is, let's just kind of dive in a little bit further. So another question someone wanted me to ask you was about exercise. So I think the way they phrased it to me was to ask that, no duh, do exercise. But I guess the question you really want me to focus on is, well, how much exercise should they be doing? And, you always have these pictures of you jumping on the beach, I had to tease you a little bit. What exercises do you recommend?
I also worked out every time we were doing the show on Chasing the Cure, by the way.
Okay.
So I love working out. I'm so happy for the person who asked this question. First of all, commit to a physical activity routine. Because once you commit to a physical activity routine, you're going to be it's going to be a predictor of avoiding weight gain.
Okay.
And set personal goals that are realistic. If you haven't had an exercise program in your life, I don't want you running a marathon tomorrow. I want you stretching. This is about longevity. And the real numbers, like if you want to go by guidelines, it's 150 minutes of moderate intensity exercise per week. So you could divide that up 30 minutes Monday through Friday. But let's say you like to go to Orange Theory. Well, right now, working out looks different right now. But if you are somebody that goes to the gym with the mask on, or you're doing high intensity boot camps online, do an online program, 75 minutes of higher intensity exercise per week is what's clinically recommended to also keep your heart strong. But you can break it up in terms of intensities. And I really want to plug on steps. So a lot of us, 10,000 steps. I got to get my 10,000 steps. 10,000 steps means you are very active. But even if you can get 5,000 to 7,000 steps, that also shows that you're moderately active. So Raj, I know you're busy today. You're in the hospital. If you can actually take steps in between seeing patients and go up and down, from radiology to the OR to the 6th floor ICU, you're accumulating a lot of exercise in your day. And the preventive guidelines have shown that it's the cumulative addition of all the exercise that you do that really reduces risk. So we need to commend ourselves when we're active throughout our day. And we can do little tricks, like I like to tell my patients when they're stuck inside, use the stairs, run up and down the stairs, or park away from the grocery store and walk a little longer to get your steps in.
I want to personalize it because people want to get to know you. So what is your go-to exercise? I know there's COVID stuff. I mean, I could tell the whole world, I'm kind of like the elliptical type of guy. I got to have my TV. I got to have my headphones. Maybe I'm cheating a lot, but I want to know because they should look you up on social media. You are definitely in shape. What do you do, Sheila?
Yeah, so I do a mix of cardiovascular work that is high intensity. So I really like to walk on an incline. And when the weather is nice, I go for like 4-mile walks, which really allow me to decompress, but there's a lot of hills. So that gets the whole posterior chain. We really have to value our lower body. So the lower body has a lot of muscle mass. And so the more you work, the lower body, the more you're going to burn at rest. So I also make sure that I do a lot of strength and resistance training. And I know a lot of women like to focus on their upper body, having toned arms, but honey's got to get the squats in because your lower body, it has so much more muscle mass and your heart rate's going to go right up. So I love doing squats. I love doing lunges. I love doing single leg work like isolation. So single leg deadlifts. These are great exercises that keep my back strong and keep me feeling like I'm getting a really good workout and I'm getting my heart rate up. Because the heavier, and you don't even have to lift that heavy, but it's really important to get that strength training in. My legs give me a lot of strength when I'm seeing patients, when I'm in the cath lab, wearing the heavy lead, as well as upper back exercise. So I do a lot of rowing and spinning too, just to strengthen my back.
Now, this is I don't know how you're going to answer this one, but another person who sent me a question for you is asking about weight, and it's kind of open-ended, so I'll let you kind of run with it. She wants to know, what is a healthy weight? So I don't know, because I look at it, everyone's different. So do you know how to answer that one? What's a healthy weight?
Yeah, that's a very difficult question. I mean, I do still go by BMI, but BMI is not perfect.
All right.
Because, your weight could be
what a
muscle
BMI
mass.
is, all that stuff, because,
Yeah. So BMI is body mass index. So it's looking at your height and your weight, and then it's creating a parameter to then give you what is deemed as a range, right? So overweight is typically, I believe, above 26 or 25.
Yep.
And so when you're in a healthy BMI, that usually encompasses the spectrum. But what BMI misses is what percentage of weight is fat and muscle.
Okay.
And there's no real good measure for that unless you really do it. This is getting like into the exercise physiology, but even getting an accurate assessment of muscle mass is very difficult, but we still do it by using, hand sensors to get muscle mass. But a healthy weight, start with BMI and be honest with yourself too. If you have BMI also, I think, underrepresents Asians.
Okay.
So certain ethnicities, Yeah, so certain ethnicities don't always get represented equally in terms of risk in the BMI, but it's important to have the discussion with your doctor. If you're concerned that you could be overweight, if things are not starting to fit, it's important to get checked out, and your height and weight is the place to begin.
All right. Cool. Well, two more questions. I'm going to throw one more fun one in there because like I was telling you, you are in shape. So can you tell my audience what is your favorite naughty food to eat that you shouldn't eat, but you eat it? You know what I'm saying? They want to know that you're human. And what is your favorite healthy food to eat?
Oh my gosh, my favorite naughty food. I can tell you what it is mainstream, and then I can tell you how I do it to make it a little bit less naughty.
Sure.
I love chicken fingers and French fries. I just love chicken fingers and French fries. So my favorite food, the way to do that, and we just did it for Super Bowl, is I love Trader Joe's breaded chicken.
Oh, yeah.
And I bake that. And then we do sweet potato fries, and we bake that too.
Okay.
I also like making my own chicken cutlet. But that would be my favorite guilty food.
Like it.
Yes, so good. And my favorite healthy food is Mediterranean food, of course. And I was so happy because my husband planned our honeymoon in Greece, and he kept saying, Sheila, it's all your favorite food. So I love white Mediterranean fish like bronzino. And I love that with like just lemon and olive oil, black pepper. And I love eating it with like a fresh green. That's like my favorite food. But what's funny is the night that he proposed, he was going to order that, right? Okay. And I said, oh, no. We can have that any day. I go, tonight, I want I want a cheeseburger with French fries. Nice. Because I am so like, tonight is the happiest night. And I want to do it with like this guilty deep meal. And I'll never forget the way the French fries came out in like a mini Le Creuset in this restaurant in the West Village in New York. And, so I think everything in moderation, when you're going to have a meal. I was just looking at a book called Why French Women Don't Get Fat. Or maybe the title is different. It's, and basically the whole book is about changing your experience with food and really enjoying your food. And so I think at the end of the day, eating should be intentional. We should be aware. Raj, when we were doing those sessions at Chasing the Cure, we'd have these like faster lunches, but then we'd go out and we had a great meal. And I think that like, it's so important to say, where can you cut the calories and have a healthier salad and then enjoy a meal when you have a little bit more time and really make it memorable?
No, totally. No, I agree. And as we kind of start wrapping things up, the last women question I want to ask you, and I think, it really comes down to when I teach my students and residents and fellows, how does it change management? That's my big theme. So my last women question for you, we're focusing on women and heart disease. Is there specific treatments for heart disease in women that are different in men? I know it's a hard one, but, can you think about something more specifically that we do for women than we do for men with heart disease?
Yeah. So one of the things we didn't really touch on how women and men can have different pathology. So when a man presents with a heart attack, we tend to see more total occlusion of the blood vessel versus with women, we tend to see plaque erosion. In fact, when you look at the data, like you look at one of the largest trials of women who presented with heart disease, the Virgo trial, there are a majority of women who present with acute coronary syndrome that do not have obstructive disease. So what happened? So you go to the cath lab, you cath them, they're having an MI and there's nothing to fix.
Wow.
So a lot of people used to say, oh, you're fine. You didn't get a stent, no heart disease. No, that is not true. What is happening is microvascular disease. And one of the medications, there's a slew of medications that really help. So when you have microvascular disease, your major highways are open, but the side streets are blocked, right?
Nice.
So traffic, So, traffic slows down if the side streets are blocked and the blood doesn't flow normally. That's a bit more in a stable condition, but in the heart attack setting, it's often plaque erosion. So heart attacks are managed the same, blockage or no blockage, stent or no stent. That's one thing. But if you have microvascular disease, I tend to use calcium channel blockers. They give a lot of arterial relaxation, as does Renexa. Renexa, also known as ranolazine, works through sodium pathways at the myocardium and causes, changes in calcium efflux and influx and relaxes the arterioles. And Renexa has been shown in one of the largest trials, Cormica, that you can actually improve quality of life in patients who were diagnosed with microvascular disease using these strategic medications. So these are medications that I lean on more in women. And just a plug for women also, women are not mini men. And it's really important for doctors to recognize you can't blast a tiny woman with atorvastatin 80 and expect she's not going to have any side effects. No, I mean, come on. We've got to do things slowly. The guidelines are the guidelines, but as doctors, we need to get the patients on statin therapies very strategically, using lower doses and get them up safely. And I often supplement with CoQ10 and vitamin D to really help with some of the statin side effects. That's important. A lot of women come to me and they're like, no, I was on a statin. And I was like, wait a second, what happened?
And then when they tell me those myalgias, those muscle aches, right? Oh, that's good, man. You're just dropping pearls left and right, I wanted to make sure this last one's not really a question. You answered that amazingly, I just wanted to make sure you get a chance to promote anything. Like, can you just say your website or any of your handles or, just what you're promoting? Then I'll say goodbye to you. Go for it.
Sure. Well, for anybody who's listening in the East Coast, I am accepting new patients, and it's really easy to make an appointment at sahniheartcenter.com. We have a great website where you can make appointments 24/7, and you can follow me on Instagram at Dr. Sheila Sahni. I'm also on Twitter, and I'd love to be a part of your healthcare journey.
Oh, that was so sweet. Only for this one, I almost wish I could put out the video because you always have this beautiful smile on your face. You're just so pleasant. And, when most people I ask, why do you want to be a doctor or cardiologist? You can kind of smell the BS sometimes. You know what I mean? I've been doing a lot of these interviews, but when you started talking about amylase in your mouth and carbohydrate digestion, you're not joking, dude. You're the real deal. And I just want to say, I make sure it's on the record. You're just an amazing person. And Sheila, I truly think of you like a little sister. I really do enjoy working with you when I was on Chasing the Cure. You're just a big, bright, shiny light over there,
Thank you, Raj. I feel the same about you.
And if I get some more cardiac stuff, do you think you mind coming back again and doing this again with me someday?
I would love to. My honor. Thank you.
You're welcome. And that is the Dr. Raj Show for today. Catch you again in a couple of weeks.
Thanks for listening. This has been a production of Ars Longa Media. Our producers are Madison Linden and Chris Brightigan. Our executive producer is Dr. Patrick Beeman. This podcast is for educational purposes only and not intended for medical advice. Ars Longa, Vita Brevis.